Morning, guys. Let me just quickly share my screen and then we'll get straight into it. Yeah. I think everyone can see that. So if there's any questions throughout, I think you can just put a question in the Q&A section. We'll sort of go through that later as well. So like I said, any questions about what we go through, any questions you have for yourself, I'll also chuck that in and then I'll try to answer as many questions as I can at the end of the session. Might give it another few minutes to see if a few more people join us. But you know what? We'll just get straight into it. If people join us later, they can just jump straight in. All right, so thanks for joining us today on a Sunday. So we're basically going to be talking about Achilles tendon pain, obviously, how you can get back to playing basketball. So basically, the aim of this webinar is really just to introduce basically a 12 to 16 week roadmap on how you can get back to playing basketball after you've suffered an Achilles injury that's basically kept you off the court. This works really well for people that have actually needed to step off the court. If people are still playing basketball, but they still have Achilles pain, you might need to follow this. You might need to adjust the roadmap a little bit because they're still playing. This is primarily for people that actually, can't play anymore because of the Achilles tendon pain. Usually that's a chronic issue. So usually these people have been having Achilles tendon pain for quite a while already. So they've gone through that stage of like trying to play through it, getting their massages, shockwave, whatever. It just got to the point where every time they play, it flares up. They're out for weeks and they eventually give up, or it starts affecting their day-to-day stuff. So walking, going up and down stairs starts to get painful. So this is really who we're targeting for this webinar. Like I said, if you're still actually playing basketball and you have that Achilles tendon pain, so a lot of these principles can still apply, but you're obviously just going to have to adjust how you're training and how you're applying it while you're still playing. So like I said, this is basically for basketball players, people who are actually sidelined from basketball due to their Achilles tendon pain, and people who actually want to get back on the court. I know in the NBA, there's been quite a few Achilles ruptures in the last season, and I know everyone's worried about Achilles injuries nowadays. So hopefully, this is helpful for some of you guys. So it's a quick introduction about myself. So I'm a physiotherapist and an exercise physiologist. I've been working here in this industry for 7, 8 years now. Unfortunately, I was one of those unlucky souls that actually ruptured my Achilles, which was probably one of the worst experiences I've ever had in sports. So that's something that I want to help you guys basically prevent. It's not a fun experience. Rehab for the Achilles takes ages. Once you actually rupture it, even now, my calf size on the Achilles ruptured side is still smaller than my non-injured side. I can play, I can run. I train Muay Thai and everything now as well. So I've gotten back to a relatively decent level of activity. However, it's something that I don't want anyone to go through. If you've got an Achilles issue, I think it's really important just to deal with it, get that sorted. Like I said, in the NBA now, the amount of Achilles ruptures going on is crazy. I mean, they don't happen often anyway, but to have what, four in the last season? I think that's the highest it's ever been. Obviously, you can get back playing. However, we want to prevent that in the first place. So, and one of the precursors of rupturing your Achilles is obviously having like Achilles issues and calf issues in the first place. So it's a little bit about me. I've worked in private practice. I played basketball since I was young. Um, like I said, since I ruptured my Achilles, I've run like three half marathons. So like I said, getting back there. However, even now, 2 years later, I still work on my Achilles. I still work on my calf all the time. But that's enough about me. So before we get into actually what you need to do when you have an Achilles tendinopathy, I think it's really important to understand the role of the Achilles tendon, what happens when you have an Achilles tendinopathy, and how the Achilles tendon works in basketball. A lot of the Achilles tendon rehab has to be done by yourself. Uh, as a physio, our job is to really guide people. I never promise anyone that I'm going to fix um, anything just with my treatment alone. They need to be involved in the treatment, which is why it's important for the patient or yourself to understand what actually happens when you have an Achilles tendinopathy, how to identify it, how to get on top of it early. All right. So Achilles tendinopathy, I'm sure a lot of you have already experienced this, but for it to be a true Achilles tendinopathy, a lot of these characteristics need to be present. So first of all, it needs to be isolated Achilles tendon pain. If you're getting really widespread pain, you're unlikely to be dealing with an Achilles tendinopathy, right? Yeah, of course, it is possible to deal with, two or three injuries at the same time as well. However, if we're looking at a specific Achilles tendinopathy injury, the, the injury or the pain has to be pretty much isolated to the Achilles tendon, whether that's in the middle of the tendon or if it's, closer to the bone, has to be along that Achilles tendon. If it's not on the Achilles tendon, like I said, if you're getting widespread pain around the calf, down into put, going higher up into your hamstrings or knee or something, it's unlikely that you're dealing with an isolated Achilles tendon issue. Like I said, possible to have multiple at the same time. However, that's where you need to be seeing a doctor, you need to be seeing a physio, so that you can actually get the correct diagnosis, whether you're dealing with one injury that's not an Achilles tendinopathy, or you're dealing with multiple where an Achilles tendinopathy is included in one of those. The second thing is stiffness. So obviously everyone's going to have some sort of pain with an Achilles tendinopathy, but what I like to look at is stiffness, especially in the morning. Usually for an Achilles tendinopathy, you're going to get stiffness after a prolonged period of inactivity or rest. So that's why that morning stiffness is usually the worst because you've been sleeping, you've been lying down for, yeah, hopefully around 8 hours, right? So being in that one position, Achilles is basically stuck in that shortened position because everyone sleeps with their foot pointed down. You're going to wake up with that morning stiffness for the first few steps, and it'll start to ease up throughout the day. Okay. So it's a classic sign of Achilles tendinopathy. If that's happening to you and you're getting that stiffness around that ankle and the Achilles pretty much up, so the morning after you play basketball, it's likely you're probably dealing with an Achilles tendinopathy. The third thing is a warm-up effect. So this is more in that sort of mild, moderate Achilles tendinopathy. When it gets really severe and you get really severe Achilles tendon pain, the warm-up effect doesn't really last as much. So what that means is usually you get pain at the start of the session. So when you first get on the court, your Achilles will be a bit sore, you might be a bit stiff, you might feel pain. But as you start moving, it goes away. So you feel pretty much normal when you're actually playing or after you've warmed up quite a bit. And if the Achilles is bad, what happens is towards the end of your session, or as you keep going after a period of time, you start to get that pain again. Okay. Like I said, when you have a really severe Achilles tendinopathy, that doesn't tend to happen because you have the Achilles pain the whole time. When it starts to affect your day-to-day function, like walking, like going up and down stairs, it's probably going to be painful throughout the whole session. However, it's important to recognize this early on. If you have that sort of warm effect of the Achilles tendon, it's likely you are dealing with an Achilles tendinopathy. And the last two pretty much go hand in hand. You get weakness around that calf. You lose your ability to explode off that leg if you're dealing with one Achilles tendinopathy. So, for example, if you're right-handed, and you've got an Achilles tendinopathy in your left leg, going for layups, dunks, things like that, where you take off with the left leg, you'll feel like you've lost that explosiveness. You feel weak. And sometimes when you feel jump, you feel like you just lost that spring. Right. Once again, classic sign of a tendon issue. Now, I just want to make a point that each one of these in isolation doesn't mean you have an Achilles tendinopathy. To diagnose an Achilles tendinopathy as a physio, what we look at is we mainly look at your physical symptoms. However, we sometimes look at imaging as well. But you need to have the clinical signs, you need to have the clinical symptoms, and the imaging. If all three match up, that's when we diagnose an Achilles tendinopathy. So going on to that, we see heaps of common imaging findings. Everyone that experiences any Achilles tendon pain, anytime you present to your doctor, in Australia, most GPs bulk bill, which means you can just go get you can just go to your GP whenever you have an injury, and they can see you straight away. They can send you for imaging, and you have pretty much no out-of-pocket cost. So pretty much anyone with an Achilles tendinopathy that goes to see their GP will have an ultrasound. This is almost guaranteed. Every time I've seen a patient with an Achilles issue that has seen their GP already, ultrasound has already been done. Usually it's unlikely that they'll do a MRI. However, ultrasound is almost always done. Sometimes an X-ray is done as well. So these are some of the common imaging findings that basically help us diagnose you with an Achilles tendinopathy. So the first one is tendon thickening. Obviously, when you have an Achilles tendinopathy, tendon gets a little bit thicker. That's a sign. Like I said, all of these signs cannot occur in isolation, and these signs by themselves cannot diagnose you with an Achilles tendinopathy. Look at this hyperechoic areas, basically you get disorganization of the collagen fibers. Pain isn't the appearance of the collagen fibers. Hypervascularity. So we know when you have a Achilles tendinopathy, you actually get increased blood flow, vascularization around the Achilles tendon. What that means is you basically grow these little blood vessels within the Achilles tendon because it's trying to repair or heal itself. Calcifications, obviously you get some fluid collection and swelling. Tendon enlargement, which is similar to tendon thickening, and increased signal intensity. This is more for an MRI rather than ultrasound. But a lot of times you'll see a lot of these occur at the same time when you have an Achilles tendon issue. Obviously, the more severe it is and the longer you've been dealing with it, you're probably going to see a lot more of these as opposed to someone who's caught the Achilles tendon pain and Achilles tendinopathy quite early on. However, it's really important to understand that the imaging findings do not equal your pain and cannot determine the severity of your injury unless you've ruptured your Achilles tendon. So the image down here is actually a ruptured Achilles tendon. But like I said, this is the only time when we use imaging to determine the severity of your injury. Here you can see the two ends of the tendon, and you see the separation here. So for an Achilles tendon rupture, obviously the bigger the gap is, the more severe your Achilles tendon rupture is, and the more likely you will need surgical treatment. That's a topic for another day. However, just be mindful that there's really poor correlation between the imaging findings for an Achilles tendinopathy and pain. So if we go back to the previous slide, someone could have, six or seven of these findings. However, they can have very minimal pain. At the same time, we can have someone that has just say tendon thickening and they got really severe pain. So although imaging is helpful, especially in the diagnosis, afterwards we don't really use the imaging for anything else. Like I said, because it doesn't correlate to pain, it's not something that we really track when we're dealing and treating Achilles tendinopathy. Right. So when we're treating your Achilles tendinopathy, what we measure is your pain, obviously, and then we measure all your functional measures. So your strength, the ability to produce power, your reactive strength, so your ground contact time. But basically, we measure the function of the tendon because we know imaging does not correlate well to pain. So, like I said, good for the initial diagnosis, but it's not something that we really focus on or even perform afterwards. After that initial stage, you don't even need an ultrasound, you don't need an MRI for you to clear you to go back to playing basketball or anything like that. The other thing is, in a lot of imaging findings, they talk about inflammation, or they don't talk about inflammation a lot. So if we go back to the previous findings, once again, there's nothing that indicates a lot of inflammation. Yeah, possibly except for the hypervascularity, yeah, and bursitis, but usually an Achilles tendon issue, inflammation is not a huge issue, right? So when you go to your doctor, a lot of times you get prescribed anti-inflammatories, like, I mean, if you're here in Australia, Nurofen, Voltaren, or something like that. However, they treat it as an inflammatory condition, whereas an Achilles tendinopathy is not purely an inflammatory condition. You might have some inflammation early on. However, when you have chronic degenerative Achilles tendinopathy, if there's actually rarely inflammation present, which is why a lot of people that actually take those anti-inflammatories make no progress, and they say it does nothing for their pain. Once again, and that's because anti-inflammatories target inflammation, whereas when you have a chronic Achilles tendinopathy, the level of inflammation is actually quite low. And so you've just got a degenerative tendon. That's also why we no longer call it tendinitis, we call it a tendinopathy, because the itis in tendinitis means inflammation. So once again, we don't use imaging to follow up. It's just for the initial diagnosis. Your physical therapy is focused on reconditioning the tendon and improving the tendon structure as opposed to exercise for pain specifically. Now, we'll talk about this a little bit later because we're not going to get too much into pain science, but exercise for reconditioning, exercise for strength, exercise for tendon health is different to exercise for pain slightly. So what happens when you actually have an Achilles tendinopathy? So we'll start on the left here. So you've got a normal tendon. All the fibers are running parallel. They're running really smoothly, nicely, mostly type 1 collagen. So that's the really stiff, the really strong type of collagen, and the one that we really want in an Achilles tendon, in the normal Achilles tendon. The second stage is called reactive tendinopathy. This is generally before you get a really chronic tendinopathy. So usually this is that first few days, you've never had Achilles tendon pain before. And then after, say a weekend tournament or something, your Achilles starts to get a little bit sore. Usually you'll just start to enter this reactive tendinopathy phase where there hasn't really been much change within the tendon yet. However, there is some inflammation around the Achilles tendon. The tendon itself can go back to the normal tendon pretty quickly. And usually you don't need a lot of therapy or exercise or anything like that because there's no major change to the Achilles tendon structure yet. You're just getting some inflammation there. So that's a reactive tendinopathy. The tendon will go from reactive tendinopathy and back to normal tendon pretty quickly. However, once you start getting into that chronic stage where you've had the Achilles tendon for that tendon issue for say months, right? You get into what we call tendon disrepair. That's when you start to get changes within the actual tendon structure. So with all our physical therapy and the exercise we're doing, our aim is to improve the structure of the tendon to try to go back to that normal state. Like I said, when you reach tendon disrepair, that's when you actually get changes within the tendon that that don't really do much in terms of performance or health. So like I said before, you get that neovascularization. So you get basically some, blood vessels, some more nerve endings and things like that within the tendon trying to repair itself. And the other thing is you get increase in type 3 collagen fibers. So like I said in that first one, we want type 1 collagen fibers because they're really strong. They're robust. Type 3 aren't as much. So if you think of it similar to muscle fibers, sorry, you have your slow twitch muscle fibers and you have your fast twitch muscle fibers. Right. So for an Achilles tendon, we say we really want that fast twitch muscle fiber. We don't want that slow twitch as much. Not an exact comparison, however, this gives you an idea how there are different types of fibers even within the same structure. From tendon disrepair, you actually can bring it back to a normal tendon with the right physical therapy, the right exercise, and obviously enough time for that tendon to adapt back to a normal tendon. Okay, so it is possible for you to be in tendon disrepair and then come back to a normal tendon, not imaging at least. Now, I've spoken to a lot of people, and a lot of people will probably be in this phase, a degenerative tendinopathy. This is where, the people that I speak to say, I've had Achilles tendon pain for years and years and years. More than likely, they've entered this stage where the tendon structure becomes a lot more disorganized. There's a lot more type 3 collagen. There's more blood vessels and things like that. Basically, the tendon itself does not function very well at all. Right. It's a lot harder to get from stage 3 back to a normal tendon. It is possible. We used to think that it wasn't. We now know that even in a degenerative tendinopathy phase, it can remodel and can adapt. Not exactly sure if we can get back to exactly a normal tendon. However, we know that we still can improve tendon structure, even in that degenerative phase, to the point where there's no pain and function has been restored. And that's also why I said earlier that imaging doesn't correlate to pain severity or severity of injury. Because we've had people that go from a degenerative tendinopathy, go back to no pain, go back to good function. But if you image them, they're probably still going to look like they've had an Achilles tendinopathy on imaging. So how does the Achilles tendon actually work, well, during basketball in general? So the easiest way to think about this is to think of your Achilles tendon like a really, really stiff spring. Okay. So every time you run, every time you jump, uh, what you're doing is just stretching that spring. So every time that foot goes in dorsiflexion, the way your toes point up towards your head, basically stretch that under load. And then the Achilles tendon basically recoils and gives that elastic energy. So exactly like a really heavy spring. And what that does is that obviously accentuates the amount of force that can be produced. Because we know muscles cannot produce as much force as the load that actually goes through your Achilles tendon. So if you think about this, it's really hard to quantify the Achilles tendon load during basketball. However, there are studies that show that running can cause Achilles tendon load up to 8 to 10 times body weight. Now, that's just running. If we add what actually occurs in basketball when you got to jump, you're taking up on one leg a lot. You're cutting, you're pivoting, accelerate a lot of acceleration, deceleration, right? A lot of lateral movement. The Achilles tendon load is probably a lot more than that, just that 8 times body weight, right? So your Achilles tendon needs to be really strong. So like I said, the Achilles tendon works as a spring because it stretches and recoils. It gives you that extra energy and power. 8 times body weight on load. I can guarantee you there's no human on earth that can contract their calf muscle and lift 8 times their body weight, right? Which is what makes the Achilles tendon so important because it allows us to handle that amount of force that goes through the ankle. That's also why when we're doing your reconditioning, your rehab, you need to be loading your tendon. How are you going to get your Achilles tendon to be able to handle 8 times your body weight of load or your calf muscle to even get close to that if all you're doing is massage, if all you're doing is stretching, right? None of that stimulates the load. The whole aim of rehab is to progressively overload and build, from down here, you're in pain, you slowly build back up to to the level that you need to be. Most people just end at start at the bottom and go straight back to the top. And that's why they keep having recurrent issues. So this is pretty much exactly what we're talking about. This is what happens when you first see your GP or you're speaking to someone that's a little older who doesn't do a lot of Achilles tendon rehab. You start with pain. So after you've been playing for a while, you get that Achilles tendon pain. The first thing you do, and the first thing everyone tells you to do, is rest. Doesn't matter if you're speaking to your friends, your family, um, other colleagues, you're speaking to your doctor, even a lot of physios. The first thing people recommend is rest. And I cannot stress this enough. You do not need that much rest. Rest is actually counterproductive for a lot of tendon issues. Now, it's okay to rest for, say, 1 or 2 days and have a bit of a break, just like you would if you go to the gym. You have 2 days before you hit the same muscle again, for example. That's absolutely fine. But a prolonged period of rest does nothing for the tendon, and if anything, it makes the tendon worse. That's still the advice that everyone gets as soon as they start getting any sort of pain, any Achilles tendon pain. I can't tell you the amount of times I've seen people that have gone to see their doctors or seen another physio, ask them what they did. They've just been told to rest, and that's literally all they did. That helps in terms of pain because you reduce the level of activity. However, it makes it really, really hard for you to get back. The next thing anyone does, or the next thing anyone recommends, is always some sort of passive therapy. So if you've experienced Achilles tendon pain, I'm sure you have sought this out yourself. I'm sure I did back in the days as well, where you go for a massage, you try some ultrasound, red light therapy, uh, TENS, shockwave, you name it. But everyone always goes for some passive therapy because what they're concerned about is the pain, and they're expecting that passive therapy to fix their pain and fix the tendon. However, we know that none of those therapies actually changes anything in the tendon structurally. So even we know a lot of things can help pain, and I'm not against passive therapies much in general. I'm okay with it, especially if you want a bit of pain relief for a short term. They're absolutely fine, but you need to understand that they are doing nothing for your Achilles tendon structure. So they don't actually help in that recovery process. There's a lot of, you might get a lot of flack for this, but there's a lot of, sort of bullshit around there. Yeah. There's a lot of marketing for, say, red light therapy saying it improves X, Y, Z. However, that's not, I haven't seen any good studies that have proven any of those things. I think a lot of passive therapies have a lot of really, really good marketing, and a lot of people buy into that. However, like I said, in most cases, in everything that I've seen, it does nothing for the tendon structure. Great for a little bit short-term relief if you need it, but it's going to do nothing for you in the long term. And usually after that, what people do is they go back to playing. So there's no progressive overload at all. They go from pain, they go back down to rest, they do nothing for a little bit, and then they go back up to playing. And then surprise, surprise, the pain returns. So this is what happens when you speak to someone and they've said they've had pain for multiple years. Usually they've gone through this cycle tens, tens of times, you know, maybe hundreds of times if they've been having it for quite a few years. But they just keep doing the exact same thing and they just say they can't get on top of it. They say they've tried everything, they've seen all the doctors, they've tried everything, but they can't get on top of it because they just keep going down the exact same pathway. The only thing that really changes a lot of times is they change what passive therapy they use. Instead of massage, they go for shockwave therapy. Instead of shockwave therapy, they go for an ultrasound therapy, right? And surprise, surprise, none of that actually works. So why does that approach fail? Well, like I said before, rest doesn't actually do anything for the Achilles tendon. If anything, you get negative adaptations to the tendon. It's exactly the same as muscles. Well, not exactly the same, but the concept is the same. If you go to the gym, if you work out your muscles, you build bigger muscles, you build stronger muscles. The same thing for an Achilles tendon. When you keep load, it maintains that strength. It maintains that type 1 collagen fiber. Orientation of the fibers basically remain parallel and really organized. However, when you rest, what happens is everything reduces. So like muscles reduce in size, you reduce in strength, and you reduce capacity. The same thing happens to your tendon. So all that rest that you're doing doesn't actually help. Like I said, a little bit of rest will save a day or two, it's fine, but you shouldn't be doing anything long term. If you're dealing with Achilles tendon pain, you need to have a consistent level of load. And this is one thing where I say it relies on you as the patients a lot more than me as a physio. I help guide, I help guide you with all of this. However, you need to maintain a capacity or some level of activity where you're not flaring up the tendon, but at the same time you're not resting too much where it becomes detrimental to the tendon. The second thing is that there's a focus on passive therapies. So like I said before, the only thing that changes is the type of therapy that you use. A lot of times I get people say massage, and they said that doesn't work for me. Then they'll go have shockwave therapy. Oh, that worked for a few weeks, and then it stopped working, and then they go for something else. A lot of times you see a sports med physician and you get your recommended injection therapy as well. So PRP, which is platelet-rich plasma injections, which is when they basically extract your blood, swirl it around, take the plasma out, and inject that plasma into the tendon, or prolotherapy, which is basically like a sugar irritant for the tendon. Similar things. A lot of these medically are aimed at improving tendon healing. However, I haven't seen any very strong evidence on that. Um, the other thing is, I don't think I've seen any very strong evidence that in isolation can improve tendon structure or healing of the tendon in any way. So I've had so many people spend money on these injections and had no effect at all. Now, when using a combination of exercise, they may be beneficial. I'm not exactly sure about that yet, or whether it's just the exercise or if the injection hasn't added any benefit. But injections on its own don't do much. And like I said, because you're focusing on passive therapies, none of these treatment methods actually reconditions the tendon to actually handle that load. And none of them change the structure of the tendon so that you can handle that load. So if we go back to previous slides where, you're handling 8 to 10 times body weight load, none of these therapies help you get back to that level. If you've got an Achilles tendinopathy, that already means the tendon can't handle that load, which is why you're in that pain, which is why you're getting that in the first place. So getting back to that level, you need to have a slow progressive program. If you're not reaching that level in your rehab, you shouldn't be playing. And once again, pain does not equal imaging findings of the tendon structure. However, the reason why we do a lot of exercise targeting the tendon structure is because that's related to performance. And usually, as you improve your performance, as you improve on the activities that you can do without pain, your pain will start to settle eventually anyway. So if we go, like what I said before, we exercise for Achilles tendon structure, improving the structure, not specifically for pain. The reason I say that is because there are so many things that can affect pain. Here in Australia, we adopt a biopsychosocial approach now, which means we talk about your biological factors, things that are just inherent to the body. We talk about the psychological factors that affect your pain, so obviously your brain and your mental health, and then your social factors. We know all three of these play together to influence the amount of pain that you get and how bad that pain gets. This is why your imaging findings do not correlate to pain because there are so many things that influence your pain. Like I said, we're not going to get into pain science too much, but just understand that there's no specific exercise for pain. I know a lot has been talked about with isometrics for pain, and for some patients it works well, for other patients it doesn't. Okay. There was a lot of hype along the early studies, and the early studies were more done on patella tendons anyway, not Achilles tendons. But anyway, um, because the patella tendinopathy patients had reduced pain after doing isometrics, everyone thought that would translate to Achilles tendon, which doesn't always occur. Like I said, you get sort of mixed results. And the level of pain that you experience, like I said, is not just dependent on your imaging findings and the structure. There are so many things like if you're fear avoided, if you're catastrophizing, if you have any mental health issues that really affects your pain. Obviously, social factors, there's not too much we can do about a lot of them sometimes. You know, the socioeconomic status, usually we know people with the poorer status, the lower socioeconomic status, usually have increased pain and usually have longer lasting pain, as opposed to people that have higher socioeconomic status. Obviously, this doesn't happen all the time. However, these are factors that we need to take into account when accounting for pain. But just remember, the exercise we're doing is for the tendon structure. Usually, your pain will reduce as you get back to activity, and it's usually not the exercise that's actually reducing your pain. So what I'd say here is ignore those influences you see on Instagram that say do this for pain. This will make you pain free. Like I said, there's no specific exercise for pain. You can try it. It can help. Um, that's why everyone gets mixed results when you look at all the comments on those types of videos. All right. So we'll finally get into the actual protocol that I use. To keep it simple, I use a three-phase approach or three steps. So the first step is we want to calm the system down. Okay. So here, the aim is to reduce the pain so that you're not getting a high level of pain with activity. Okay. In terms of the exercise focus here, we do a lot of isometric work. Like I said, sometimes this can be beneficial for pain. However, the main reason why we do these isometric holds is because this is usually the type of exercise that people can tolerate when they have a lot of pain. So this is the exercise they can tolerate, but at the same time, your isometrics can do really good stuff for your Achilles tendon. So it can improve your tendon structure, it can improve your tendon stiffness. Right. So usually if they're really aggravated, you can't tolerate those high level of Achilles tendon loading anyway. That's why we start with the isometrics. In this phase, we want pain to be manageable, so it needs to be pretty much at least under 3 out of 10 the whole time. We don't want constant flare-ups because you get this sort of yo-yo effect, right? And that then they end up at the same level. We want to keep pain at a low level so that we can have a consistent base and build on that base. The reason why people can tolerate isometrics generally for this phase is because there's no movement. We can keep it really heavy, but because there's no movement, it usually doesn't affect the Achilles tendon that much. So, if we go back to what I was talking about before, how the Achilles tendon works, like I said, it works like a spring. So for the spring to work, it needs that stretch and recoil. In isometrics, there's none of that. So you're getting a heavy load, but you're just holding a specific position, which is why most people can tolerate this early on. So this is the first phase. So once again, you do not need to rest. In this phase, we're managing your Achilles tendon pain. So specifically for your Achilles tendon, we're doing a lot of isometric work. However, this doesn't mean you rest. For your cardio, you can still do some walking. I've got people walking up on an incline on a treadmill because they've had an Achilles tendon pain. They can't run, they can't play, but they can still walk. And I can guarantee you, if you're walking up a really steep hill at a decent speed, your aerobic system and your cardio is going to be working. You can do bike or swimming as well. Low intensity, low impact activity that it can be done at a high intensity for your cardiovascular fitness or aerobic fitness. Strength. You should be in the gym if you're playing basketball. However, if you have an Achilles tendon pain, you still can train all your upper body. You can train everything in your core. You still should be able to train a lot of your lower body exercises. Okay, so squats should still be generally okay. Deadlifts should be okay, right? because they don't load their Achilles that much. If your pain is super, super aggravated and the squats are affecting your Achilles tendon pain, there are ways we can modify things, right? There's no reason why you should give up on your strength training because you've got Achilles tendon pain. There's no reason why you should stop doing your cardio. Basketball specific things that you can do in this phase, shooting, right? Shooting is not super high Achilles tendon load. If you can walk, you can shoot. Okay. If you're actually playing games, you can review video footage, the tactics, things like that. You can also do drills and at a slower pace, at like a walking pace. All right. So you can still do things on the court. You can do passing drills and things like that as well. Um, here, if you're really, if it's super, super aggravated, I'd say concentrate on your shooting. Unless you're Steph Curry, most people probably could improve their shooting anyway, regardless. So like I said, don't need a rest. You need to keep some level of load, even at this phase. This is the phase where everyone is told to rest and they do absolutely nothing, right? That's, like I said, that's the worst thing you can do. These are a list of activities that you can do. The second phase is once that pain starts to subside a little bit, or if there's a little bit of pain, we can progress to phase two. The aim of phase two is to improve your maximal strength, especially around the calf. Everyone with an Achilles tendon issue, I will almost guarantee 99% of the time the calf is weak and they do their calf raises incorrectly. I'm going to say that again. Everyone with an Achilles tendinopathy will have weak calves, guaranteed. If I actually anyone that I've tested with an Achilles tendinopathy has never tested with good calf strength or endurance. Okay. So you'll see some influencers and people on Instagram that say, "Oh, you've got Achilles tendon pain. You got to work your hip, all right? You got to work your knee or whatever, work your glutes, whatever." Now, all of that can play a factor, and that can help. However, if you have an Achilles tendon issue, you need to address the Achilles tendon directly. Although things can help, but you need to do something for the calf. You need to do something for the Achilles tendon. And here's where we introduce that to heavy, heavy, slow resistance training. We slowly increase your volume, but the aim here is to create positive adaptations for the tendon. Right? We know that heavy, slow resistance training makes your tendon stiffer, makes the tendon stronger. When I say stiffness in this case, it's a good adaptation. So like I said, think of a really strong spring. The stiffer the spring is, harder it is to actually pull apart. And that's exactly what we want. And when you do pull it apart, harder it recoils. So this is really what we'll be doing with this heavy, slow resistance training phase. You'll be doing heavy, heavy calf raises. When I say heavy, I'm talking about at least 80, at least 90%, one rep max for your heavy, slow resistance training. We'll get to that in a sec, but in terms of exercise programming, once again, there's a lot of things you need to do. You do not need to rest. Aerobic and cardiovascular, bike, swim, walk, what we talked about before. But here in this phase, you can probably start reintroducing running as well. Now that needs to be done in a gradual and progressive manner. However, this is the phase where you can start again. Strength. At this phase, you should be able to do every single exercise in the gym, except for your really, really explosive plyometric type of exercises. What are your main exercises in the gym you should be able to do? Achilles specific exercises. This is where we do your heavy calf raises. Once again, this has to be heavy, and this is where everyone goes wrong. You can work your calf raises endurance with single leg calf raises, which is really important for Achilles tendinopathies. However, you need to improve your maximal strength as well. A lot of times I see people that have seen physios and they've said they've done calf raises. Okay. There's two things that I see wrong all the time. And people say calf raises doesn't work for me. I've already done calf raises. Physio's already given me calf raises. Two things I see wrong is intensity is always super low. So the amount of times I've seen players doing calf raises on two legs, just holding a dumbbell or a kettlebell. That is less load than doing your Achilles, so your calf raises on single leg. It is doing absolutely nothing for your Achilles tendon. It is not going to help you at all. It is a complete waste of time. I'm okay with double leg calf raises. You need to do it heavy. Right, like I said, we're going 90%, three, four, 5 sets of, 4 to 6 reps, even lower. The second thing is the calf raise technique is always off. Key points when you're doing a calf raise is, or standing calf raise, is doing it with your knee completely straight, going all the way up and all the way down, and making sure you're moving vertically. A lot of people, especially if they're just holding onto a dumbbell or kettlebell, and they're not doing this in a machine that moves just up and down, they start to shift horizontally and sort of go this sort of diagonal angle. You need to ensure you're moving completely straight up. And I said you need to keep your knees completely straight. That's going to work your gastroc in a lot more. Um, so that's where I see a lot of people have this weakness where they can't keep their knees straight. They need to bend the knee a little bit to be able to do their calf raises. Okay. Obviously, here we're going to be doing bent knee calf raises as well, which is once again super important. However, once again, it has to be heavy. I've seen heaps of stuff on Instagram where they're doing things like, oh, you have to do these lunges on your toes or half raises on your toes. Guaranteed you, I'm going to guarantee that's not going to be enough load because two things. One, you're just reducing your body weight. And two, your quads are going to fatigue before you even hit failure on your calf. Sure, it's hard. It's hard to be balanced, right? The muscles are going to be working, but it's not enough load to create specific adaptations. Bent knee variations like seated calf raises are really important. However, the most important, if I had to prioritize, is your straight leg work in standing calf raises. People say your bent knee calf raises are for your soleus, which they are. However, there are studies that show that even just doing normal straight leg standing calf raises improves your Achilles strength and mass a lot more than doing bent knee variations. So like I said, the priority is standing calf raises. Bent knee can still work well. However, I would always prioritize standing. In this phase, we can also start to introduce some light plyometric stuff. So some pogos, a bit of skipping. Realistic jumps can be introduced. Once again, box jumps are not really plyometric exercises. The contact time and the time to actually explode up is a lot longer than when you're actually running, jumping, running, skipping, or cutting, pivoting, taking up on one leg. Which is why they're usually fine for this phase. They're not super high in Achilles tendon load, despite what people think. Um, they're going to be fine. The things that are really going to affect the Achilles tendon is that speed. And basketball specific things you can do, obviously your drills, and then you're starting to introduce the speed into your specific drills and practices. This is where monitoring symptoms is super, super key because this is where a lot of people can flare up. So when you're monitoring your symptoms, there are three things that I want you to remember. That's your pain during your activity, pain immediately after your activity, and pain and stiffness the next morning. So if we're in that the 1 to 3 out of 10 for all of these three, generally we're okay. We can keep progressing. If you're hitting 4 to 5 out of 10 pain in any of those three, we need to proceed with caution. Okay, so we're probably going to stay with a similar load and see how you tolerate that for the next week or so. We're probably not going to increase anything. And if you're getting a 6 out of 10 or more than a 6, we need to pull back a little bit. Okay. So this is where monitoring symptoms become the vital. Like I said before, you don't want this yo-yo effect. You want to have a consistent level that you can slowly build over time. Okay. And here comes the last phase. So this is where we restore the spring of the Achilles tendon. This is where all your plyometric things come into play. This is where we're building your reactive strength and reducing the ground contact time. So when we're talking about Achilles tendon load, there's two things we like to talk about. One is the absolute magnitude of load. So, for example, if you're doing a squat, it's a weight on the barbell. The other thing that really affects the Achilles tendon is the speed, which is why the initial two phases have been done. Well, the first phase, you focus on isometrics, which is no speed at all. The second one is done slowly. And here is when we start to gradually increase that speed, right? Because that's going to really set off that tendon if you're not prepared for it. So I won't go through the aerobic and strength stuff. We'll just talk about the Achilles specific stuff a lot more. But here, you need to maintain your heavy calf work. After the last phase, what everyone does is they stop training their calves because they think the Achilles tendon is good, your calf is good, you don't have to worry about it anymore. You need to maintain your calf specific training. And for the rest of your life, or at least the rest of the time you play basketball, you probably should be. The main aim of this phase is the plyometric things. So we're doing progressive jumping and variations and multi-directional work, gradually increasing the amount of Achilles tendon. So here's where you do a lot of that really that springy work, where as soon as you land, you're jumping straight back up. Okay? So this is just a quick example of plyometric progression. I mean, not everyone really follows this to the T, but at the lowest tier, we got your extensive bilateral hops and jumps to offset two legs, and you just do little pogos and things like that. But you're doing these as a low intensity for a longer period of time, hence extensive. Next, you can move on to extensive unilateral. So that's basically one leg. So I think single leg little pokers and things like that. Next phase can be intensive bilateral hops and jumps. So this is when you're really thinking about exploding up or forwards, vertical or horizontally, and you're going basically maximum effort here. Okay. Next one, same thing. You go from two legs to one leg. Same thing, super high intensity, and trying to really shorten that ground contact time. So once again, as soon as you land, boom, straight back up. Then we get sprints. The basketball, we probably don't need to hit max velocity much, but we really need to work on your acceleration, which is super high Achilles tendon load. Max velocity is, but because the court size is too small, most basketball players will never actually really achieve their maximum velocity. Okay, so because the court is so small, once you accelerate, by the time you get to a point, you're gonna have to decelerate anyway. So no one really reaches their max velocity. If you have time, we can work on that because that's really high Achilles tendon load and really good for plyometric progression as well. But for basketball players specifically, acceleration, deceleration, name of the game. And then obviously you go back to full scrimmage of the game for the super high plyometric load in general anyway. The mindset for your Achilles tendon rehab should be focusing on performance, not specifically for pain. If all you're doing is chasing pain, you're never going to get better. You're never going to recover, and you're never going to get back onto the court. Like I said, there are so many things that can influence your pain. There are so many things that work in the short term. However, for Achilles tendon rehab, you do need to improve that tendon structure to be able to get back onto the court and improve that performance. Once that happens, generally you reduce your pain anyway. But if all you're doing is focusing on pain treatments, you're just going to keep running into things like your shockwave and things like that, which can help, but they're generally short term. Second point is pain-free. Pain-free doesn't mean good performance or that your tendon's healed. So pain-free, we can get you there just by resting. Honestly, most active players with an Achilles tendon issue, if you just rest, I can almost guarantee, that you'll be pain-free. That's not because that the Achilles tendon is healed, it's because you've just reduced your activity, right? You've reduced the amount of load that Achilles needs to do. And that's why you're not in pain anymore. And a third thing in terms of mindset is you need to be putting in the work rather than relying on your classic modalities. So even when I work with my clients, they need to work. I expect them to be doing a lot of the rehab. They need to be compliant with all of that. You need to be making sure you're monitoring your system so you're not aggravating things all the time, right? So rather than looking for a fix, you need to be the person that does something about your Achilles tendon thing, rather than look for someone else to solve your issue. So basically, the recap is we have phase one, we try to maintain pain or reduce pain, reduce stiffness, but we still want to keep active and keep some Achilles tendon loading. Phase two is when we do that really heavy strength training. Then we're building tolerance, we're building strength within the tendon, and then getting those positive tendon adaptations. And then phase three is when we really dial into those plyometric progressions to get you back on the court. So I'm going to stop sharing my screen now. I don't have time for some questions if anyone has any. No one has any real questions, and we'll pretty much just wrap up. So I've made this about an hour and a half just in case anyone had questions. But like I said, if no one has anything, we'll just wrap up. So if you have any questions, just chuck it in the Q&A section. So probably not like anyone really has any questions to me. Microphone. Someone's asked, you have more specific breakdown how long each phase usually lasts. The clients, for example, phase one is 3 to 4 weeks long. So this really does depend. Each phase will generally go for a few weeks. So, for example, if you say 12 to 16 weeks, that first phase would generally be, for me and my clients, be about 2 to 4 weeks, and that depends on how they progress. Usually it's not longer than 2 weeks, to be honest. We might get to that 4 weeks if someone's super like aggravated, but that phase is generally pretty small. The majority of the rehab is going to be phase two and three because one, as we know, with exercise, you're probably looking at 6 to 8 weeks before you get any real positive and really good adaptation. So that second phase is probably going to be for about sort of at least 4 to 6 weeks. Um, like I said, in the phase three, you continue strength training anyway. So you're still going to continue getting those adaptations, but usually that's probably for at least 4 weeks. And same thing for the last phase will be at least 4 weeks because we need to go through those progressions. And people can't progress that fast, especially if for these clients that have stopped completely playing because of their pain. So they're at zero now, right? So to build back up to that level, we'll need to take some time. But generally I'd say generally about 4 to 6 weeks for that as well. Uh, Someone's asked what specific assessments do you use to track progress? Force plates mostly. So in terms of specific assessments to track progress, force plates can be really beneficial. Um, if I'm working face to face with clients, then those can be used. But generally, if we're working online, I don't know if you guys have any online clients that have access to force plates. But I think so. So usually not. But face to face, force plates are good. It's important to remember though that isometric strength doesn't doesn't correlate really well with actual isokinetic strength or plyometric strength. So that's only one measure. Okay. Force plates are sort of good for that maximal isometric strength, but if you change positions as well, the isometric strength is going to change. So you just need to be mindful of that. But that's one thing that you definitely can use. One thing that I would use is if you're working face to face. The second thing is are you is rep maxes. So generally you can go to say a 1 to 4 rep max because you can predict your 1 rep maximum pretty accurately of calf raises. So your maximum isokinetic strength. Once again, that's something that if you're working online with clients, you want to make sure they video it to make sure that the technique is good. Because people will be pushing a lot of weight, but you see them doing really shit technique. Um, sometimes bending their leg, doing like sort of like a little squat as well, because they go on their toes, they think they're doing a calf raise. Third thing is calf raise endurance. So a single leg calf raise to a metronome, 60 beats per minute. Once again, ensuring technique is perfect. I want pretty much all of my clients speaking at least 25 with good technique, at minimum 25 on each leg. That's calf endurance. You can add weight to that, and if they can, that's awesome. But that's at a minimum body weight, single leg calf raises from flat, then no dorsiflexion. Um, those are probably the three biggest things that I measure. But you can also measure mobility. Usually that's early on. Sometimes if someone's really aggravated at the start, they can't really stretch their Achilles tendon, so they need to warm mobility might be reduced a little bit. Um, so early on, you might want to track the mobility as well. But once you sort of get past that phase, you don't really have to be honest. But to summarize, yeah, isometric strength with force plates, isokinetic strength just doing normal rep max testing, whether that usually with Smith machine. If you don't have access to a Smith machine, you can use something else, but that's generally what I use. And then calf raise endurance test. Those are the three main things. Oh, sorry, I forgot one more thing. Your reactive strength. Doing a drop jump. Drop jump. So off a 30 centimeter box, you can do one leg, 30 centimeter box, drop off, jump straight back up, measuring that reactive strength. You can use force plates to do that. If you're working with clients remotely or you don't have access to force plates, My Jump 2, awesome app, and has actually been shown to be pretty accurate. So that's something you can use for reactive strength as well in phase. Next question is, are there any lower body lifts that you would completely avoid during phase one or any of the phases? Lower body lifts generally, not really. If we're talking about traditional strength, if we're talking about traditional strength training, there's no real lifts that you really need to avoid, to be honest. Sometimes if they're really aggravated, like I said, they can't handle that stretch. So that's why sometimes the squats can aggravate a little bit. But generally, if they can have decent knee and wall mobility, they can still squat. Um, there's no real lower body lifts that allows Achilles tendon that much because it's all usually done in a really slower, controlled manner, and there's no speed to it. So the tendon doesn't actually have to work much at all. It's all muscle work. Like I said, deadlifts are fine. Split squats are generally going to be fine. Lunges are fine, because they're not. The only thing is squats will put your ankle into dorsiflexion a bit. So if you're really aggravated, they can't handle that stretch all the time. But deadlifts, you get less of that dorsiflexion, which is why it's generally tolerated still fine. Lunges is the same thing. You don't get into a huge dorsiflexion, so that's generally fine as well. But because they're studs, like I said, the Achilles tendon works as a spring. So if you're not getting that really sort of big stretch in the tendon and recoil, then they're generally going to be fine. And that's why in the first phase we do isometrics and second phase is heavy slow resistance training because they can tolerate that slower speed. And you can still keep the intensity high. So if someone's got an Achilles tendinopathy, they can generally still do really heavy deadlifts and really heavy squats. Right. Obviously be mindful of pain. Um, but generally they're okay. Generally I don't avoid a lot of training at all. The only thing I avoid is like the only thing I'd always avoid is pretty much all your running, jumping, and things like that if it's really aggravated. Squats, deadlifts, and lower body lifts is all dependent on the patient. All right, cool. No more questions, so we'll just wrap up here. Well, look, thanks for attending. Like I said, this is really for people who play basketball who really want to get back. So if you want to get back and you want to work with me, send me a DM on Instagram. And everyone that's on this webinar has found me on Instagram or saw the ad on Instagram, so you should be able to message me there. So if anyone needs help, you can book a free consultation. Just message me and we'll arrange a time, and we'll basically meet like this on Zoom. Talk about how we can help you with your Achilles tendon pain. Otherwise, that is pretty much it. Thanks for coming, guys. We finished a little bit earlier. Yeah, yeah, we finished a bit earlier. I thought there'd be more questions, but that's okay. So yeah, thanks for coming. I'm gonna stop this now.